Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Dan Burton, CEO of Health Catalyst. Welcome, Dan. Thank you for joining us.
Thanks for having me, David.
In a few words, are you able to describe what Health Catalyst does? I know that's a tall order because you do a lot of things, but where do you come into the healthcare equation?
Sure. So we primarily do three things for our clients and on behalf of patients. The first is that we provide a data platform. We aggregate data from hundreds of different sources, bring it into a single source of truth, and allow our health system clients to then use the data at the apps layer to analyze. That's the second thing that we help with. We've built a few applications that analyze that data and pinpoint areas for improvement. And then the third thing that we do is we offer expertise in the form of services so that when one of our clients decides on a few projects that the data has guided them to, we can also help them actually execute against those improvement projects and realize the actual improvements. So those are the three things that we fundamentally do.
Right. So a lot of your clients are healthcare provider organizations. For years, the electronic health record has really been the cornerstone of most organizations' IT programs. And I think it's fair to say at this point that many people are recognizing that it's not delivering on the promise standing alone. We're all wired or wireless, and what's happened as a result is quality improved, and costs gone down. It seems to me that the electronic health record alone is not going to carry us into the future. So what are some specific things, some concrete examples of things that you're doing with your client customer organizations that are building on or maybe taking the next step beyond the electronic health record?
Sure. I think I agree with your characterization that the move from paper-based records to electronic medical records was necessary but not sufficient for us to harness the true value of all of the data related to an individual and an individual patient. And so a lot of what we do is we take the data from the EMR, but we then couple it with hundreds of other sources of data so that you get a much more complete picture of the clinical, financial, operational perspective of all the encounters, all the data related to a patient, so that you can make better decisions. In analyzing a more full data set, where we have hundreds of sources, not just one source, you get a much better view, and you can pinpoint specific opportunities through analytics for actual improvement. And oftentimes there are thousands of opportunities when you have the right full data set to draw from. So we focus on getting the data set full of many, many sources. Most of our clients ingest data from dozens, if not hundreds of sources to complement the data in the EMR, which is always going to be very relevant and important, but it's usually not sufficient to do the kind of comprehensive improvement work that all of our health system clients need to do.
Right. So what's a concrete example of something that's not in the EHR, but that is being brought in by one of your clients or one class of clients? What sort of analytics are you able to perform by bringing that data in that you're not able to do otherwise? And how does that inform the process of care?
Sure. There are many examples, but one concrete example would be when a health system wants to work on readmissions reduction, for example. When you think about what causes a readmission, there are often multiple variables at play. And being able to source the clinical information in the EMR, but then complement it with often other clinical information. There could be a lab system that is separate and apart from the EMR that needs to be brought in, but also patient experience information and financial information about the patient, socioeconomic information that could help you predict while the patient is still within the four walls of the hospital that they may be at a higher risk of readmissions for a myriad of factors. So part of what we are able to bring is we bring all of that data into the data platform. We have built healthcare-specific logic and algorithms that look across financial, operational, patient experience, and clinical data to predict who might be more likely for readmission. And in near real time, feed that information back to the provider organizations so that they can make better decisions about the care of those patients to minimize the risk of readmissions. And to do that, you really have to look across more than just the EMR data.
Right, sure. And then it's out of your court and up to your client to figure out how do we address these, whether it's social determinants of health and housing security, food security, other kinds of things, transportation to appointments, I suppose. That all becomes the healthcare provider's problem rather than your problem, that at least you've identified and hopefully tied a bow around it, presented it to them in a way that's actionable.
Well, I think you're touching on a really important trend we see repeated over and over again, which is the technology alone is rarely enough to see outcomes actually improve. And that's one of the reasons why a few years ago we decided we needed to complement technology with expertise as well. So we'll actually stand side by side with our provider clients. When they decide they're going to work on readmissions, we don't just bring the data to bear. We bring experts who improve readmissions at other health systems as well. And we work together on whatever it is that the data guides us towards needing to improve. And we stay there until we achieve the readmissions reduction that we set out to achieve. So we're very focused on getting all the way to outcomes actually improving, which is really hard. It requires a lot of behavior persuasion in addition to the right data and the right technology. So it is a complex process, but we find it really fulfilling when you stay around long enough and you're willing to be a long-term partner to actually see the outcomes improve. That's very meaningful.
Right, sure. And the persuasion, I take it, is not only persuasion of the patient to change his or her ways, but persuasion of your clients to change
Absolutely.
their ways, their approaches. Do you find that many of them are relying on alternative payment methodologies in order to finance these efforts?
Somewhat. I think that economic transition has been slower than a lot of us thought it would take. And that's certainly our experience. We, on the one hand, see almost all of our provider clients dabbling in some way with regards to value-based payment models. But on the other hand, still, I would estimate across our major health system clients, around 90% of their payment model is still traditional fee-for-service. And so while there are some mechanisms or incentives to work on things like readmissions reductions, still the bulk of the economics flow through a fee-for-service mechanism. We are, though, benefited by lots and lots of provider clients that want to do the right thing because it's the right thing to do. So we try to help them in that regard. But the economics, I think, are lagging. They're taking a little bit longer than what we had anticipated a few years ago.
That's frankly surprising to me that such a large percentage of your customer base is still working on a fee-for-service basis. Maybe that's indicative of who it is out there that requires your assistance more than else. Folks who are sort of not far along enough on that journey thus far and need the helping hand to bring forward.
I think that's an interesting hypothesis. I would relate that I actually think it depends on how you answer the question. So on the one hand, if you ask a health system, what percentage of your payment that you receive is in some way affected by shared risk, you could get a very high number, right? A very high percentage. But when you actually drill in, sit down with a CFO and say, how does this actually work? Oftentimes it's less than 5% of a large chunk of payments that are influenced by anything but fee-for-service. And we work with almost 500 hospitals, 5,000 clinics that treat over 90 million patients. So we have a pretty good cross-section of the entire healthcare ecosystem. And I would hypothesize that our client base looks a lot like the broader population. So I think we have some really innovative clients like Kaiser Permanente, UPMC, Partners Healthcare, Stanford, that have a pretty significant mix of fee for value versus fee for service. But there is still a really significant chunk of all of our health system clients' revenue that's still fee for service.
So some of your tools, as I understand them, are geared towards helping folks in alternative payment models and ACOs.
Yes.
I'm wondering if you could speak to that a little bit, talk about what is it that you're able to bring to the table for an ACO, although of course definition for ACO keeps changing.
Yes.
And different models are being put on the table by the federal government, and we keep hearing from the government that they're interested in certainly moving people away from two-sided risk sharing. Two-sided risk sharing, away from one-sided upside sharing only. And just wondering whether you see a real opportunity there for the providers. Is this something that can really drive healthcare quality improvement as well as cost reduction? An opportunity both for providers and for patients, frankly. There's some who would say that the ACO is not living up to its promise in general concept, that it really just sort of putzing around the edges and not really dealing with significant dollars, significant changes. I don't know if you have a different perspective.
I would agree with that assessment. I think it's a step towards fee for value, and many of our clients were pioneer ACOs, for example. Alina Health was a pioneer ACO, a member of a pioneer ACO, and several others, Partners Healthcare and others. And I think the ACO construct has been useful to help providers start thinking differently about the economics of the relationship, but they are somewhat a symptom of what we were just describing and talking about, that a small enough percentage of payment, is actually at risk in an ACO construct that you still find these health systems having to operate in two very different economic models. To be clear, the fee for value economic model, I think, is incredibly important and fundamental to healthcare transformation. And we want to help accelerate that process. When that economic model shifts to a true risk-based upside and downside fee for value model, the fundamentals of what a provider cares about from a data perspective completely change, where the fee for service model is a volume-based, revenue-based, quantity-based business model. The fee for value per member per month model is a cost-based model, where now you want to gear your entire ecosystem around understanding your cost structure. And what's fascinating to me, I studied economics my undergrad was in economics. And when you see the effect of the entire technology infrastructure that's built around a business model centered on fee for service, they're very good at precisely identifying volume drivers, revenue drivers. Sure. Very poor at measuring and precisely monitoring cost, which has, I think, in many ways driven up the cost of healthcare very, very significantly. On the flip side, when you change the economic model, you need a whole different apparatus. You need a whole different measurement infrastructure. And it's one of the reasons why we've invested over the last 4 or 5 years with our partners at UPMC, developing a precise costing application at the apps layer that both helps capture the data that you need to actually know at an encounter level, at an individual level, what it costs for your knee replacement versus my knee replacement at one location versus another, with one provider versus another. And all of a sudden, that becomes the primary focus of the entire healthcare ecosystem. That will be a revolutionary change. And we see huge gaps in most health systems' ability to precisely measure costs. But we think over the next 10 years, as the economic model shifts more, there will be much more focus on the cost side of the equation, and that will lead to a lot of improvement in terms of patient outcomes and total cost of healthcare in the U.S. But it'll be painful.
Yes, change is often painful.
Yeah.
We're talking revolution. If you're just tuning in, this is Harlow on Healthcare coming to you live from HIMSS 2018 on Healthcare Now Radio. I'm David Harlow, and my guest today is Dan Burton, CEO of Health Catalyst. So we're talking about cost, and many have said in recent days and months that if we could just reduce prices, that's sort of what sets the U.S. healthcare system apart from other systems around the world. We need to reduce the cost, reduce the price to the end user, and that will solve many problems. We're talking about measuring and tracking a lot of different sorts of indicators, and over time, there have been many programs that have tried to track different measures and then tie reimbursement to incentives to progress against those measures. And whenever I read about these things or get involved in these things, I always think of the Lake Wobegon effect. It's where all the children are above average. So some of these measures that we measure, just in the meaningful use arena for one, measures, everyone knew they were being tracked on measure X. So everybody did wonderful at asking their patients about X. Were the patients healthier as a result? Don't really know. But they got their incentive dollars. And then that came off the table as a measure. And incentives are directed in another direction. So tools like the ones that Health Catalyst provides can continue to help individual provider organizations improve care at the individual level, patient level, population level. But key driver in this whole equation is reimbursement, value-based reimbursement, which, as I said, is often tied to improvements to individual measures or sets of measures. Do you think that we're at a point where we've all improved so much that it's unclear what we do next? There's always room for improvement. We have a set of measures that we're being measured against, and where are we with that? Do we need new measures? Do we need different measures? Do we need a whole different approach? What's your take on our current predicament?
I don't think we're anywhere near finished with. I would say we're in the first inning or maybe second inning of a major transformation from a cost structure perspective relative to where we need to be as a country and even beyond the U.S. And I liked your analogy about everybody being above average. I think that's one of the challenges in cherry picking a few measures where you can sort of squeeze the air in the balloon to a different part of the balloon. Whereas I think the fundamentals of more of an economic model where you get a fixed amount for a population of individuals, and you got to budget within that amount, and you got to prioritize and optimize the way that you manage and help that population, and you got to involve lots of constituents in that process, way beyond the healthcare delivery ecosystem. But when you do that, I think there are tremendous opportunities to let the data guide what will make the biggest impact. And it includes persuasion. It includes persuasion around behavioral decisions. And we've got to ask questions about who is in the best position to persuade with data the individual to make better decisions about their health. And one of the applications that we built to help in that regard, that doesn't just show where you're above average, it does show where you're below, is our benchmarking touchstone application that we just launched this last week. It takes our database of over 100 million patients and uses machine learning algorithms to pinpoint for a given health system exactly where they deviate from what we would expect through our algorithms to be the expected outcome, both in a positive direction, so it's good to see where you're strong as a health system, but also, at least as importantly, where you're very far off what should have been, based on our algorithms, the perceived outcome from a financial perspective, from a clinical perspective, and then it prioritizes those areas where there's the biggest variation, where you're falling below average, and where others have successfully made improvements in a high ROI way to try to help you prioritize where to focus your time and energy. But we see thousands and thousands of those kinds of improvement opportunities at every one of our clients. So I think we're early in that process.
So I was going to ask, sort of, what data types, data sources do you see as truly predictive? And what I hear you saying instead, or not instead, what I hear you saying is that you've built an AI that can figure out on a dynamic basis what are the measures, what are the data sources that are important in any particular situation. So the fair characterization.
Well, I think it is in the context of our earlier discussion that it can be a good support, it can be a good guide for individuals who want to make decisions, but I wouldn't presume that the technology alone would be enough to affect the persuasion that has to take place for individuals.
We're not going to plug it in directly yet to make changes and drive the car.
Exactly. But it can be a very useful tool, very useful prioritization to figure out where we're going to get the most benefit from our areas of focus. If we have limited dollars, we have limited time, this helps prioritize.
Are there any other particular tools that you have built that you see getting significant traction, that helping your clients in this domain?
Well, one other that I would mention at the apps layer. So we've talked about costing, that we're really excited about helping precisely measure costs. We're excited about benchmarking. We also do a lot of work with our clients around patient safety and reducing all-cause harm events. And we have, for many years as a company, focused on that. And we're about to launch in the next 6 weeks our next generation of patient safety technology applications that are supported by all the data that's already in our data platform and augmented by clinical experts on the services side that can help our clients reduce those patient harm events in a really significant way. So that's the other thing I think we're very passionate about, that we share that passion with our clients to see patient injury prevention uptake and reduce those patient safety issues.
Great. I'm going to ask you one final question, which is, if you were to wake up tomorrow and find yourself 5 years in the future, what is one thing in healthcare that you would hope or expect has changed dramatically?
I do hope that the economic model has changed a lot more than the 90-10 split that we talked about. I think the closer it is to a tipping point of 50-50 or more than 50% in a true at-risk fee-for-value model, I think the more hope that I have that we will really focus on how we improve and get more effective and more efficient. So that would be my hope, is see the economic model shifted in 5 years, and that will drive lots of other really positive secondary effects.
Well, thank you very much. I hope that comes to pass.
Thank you, David. It's great to visit with you.
It's been a pleasure to speak with you. You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.